Intracapsular cataract extraction. Presently, the technique of intracapsular cataract extraction (ICCE) is obsolete and sparingly performed worldwide. However, the surgical steps are described here as a mark of respect to the technique, which has been widely employed for about 100 years over the world, and is an important landmark in the history of cataract surgery. Surgical steps of the ICCE technique are as follows. 1. Superior rectus bridal suture is passed to fix the eye in downward gaze, Fig 9.23a. 2. Conjunctival flap fornix-based is prepared to expose the limbus, Fig 9.23b, and hemostasis is achieved by wet field or heat cautery. All surgeons do not make conjunctival flap. 3. Partial thickness groove or gutter is made through about 2/3 depth of anterior limbal area from 9:30 to 2:30 o'clock, 150 degrees, with the help of a razor blade knife, Fig 9.23c. 4. Corneoscleral section. The anterior chamber is opened with the razor blade knife or with 3.2 mm keratome, and section is completed using sclerocorneal scissors, Fig 9.23d. 5. Iridectomy, Fig 9.23e. A peripheral iridectomy may be performed by using iris forceps and de Wecker scissors to prevent postoperative pupil block glaucoma. 6. Methods of lens delivery. In ICCE, the lens can be delivered by any of the following methods. I. Smith-Indian method. Here the lens is delivered with tumbling technique by applying pressure on limbus at 6 o'clock position with lens expressor, and counter pressure at 12 o'clock with the lens spatula. With this method, lower pole is delivered first. 2. Cryo-extraction. In this technique, cornea is lifted cataracts. The surgical techniques of ECCE presently up, lens surface is dried with a swab, iris is in vogue for adulthood cataracts include. Retracted up, and tip of the cryoprobe is applied on the anterior surface of the lens in the upper quadrant. Freezing is activated, -40 degrees, to create adhesions between the lens and the probe. The zonules are ruptured by gentle rotatory movements, and the lens is then extracted out by sliding movements. In this technique, upper pole of the lens is delivered first, Fig 9.23f. 3. Capsule forceps method. The Aruga's capsule holding forceps is introduced close into the anterior chamber, and the anterior capsule of the lens is caught at 6 o'clock position. The lens is lifted slightly and its zonules are ruptured by gentle sideways movements. Then the lens is extracted with gentle sliding movements by the forceps, assisted by a pressure at 6 o'clock position on the limbus by the lens expressor. I. Irisophake method. This technique is obsolete and thus not in much use. V. Wire vectus method. It is employed in cases with subluxated or dislocated lens only. The loop of the wire vectus is slid gently below the subluxated lens, which is then lifted out of the eye. 7. Formation of anterior chamber. After the delivery of lens, iris is reposited into the anterior chamber with the help of iris repositor, and chamber is formed by injecting sterile air or balanced salt solution. 8. Implantation of anterior chamber. ACIOL, see Figs 9.23g and h. For details, see page 210. 9. Closure of incision is done with 5 to 7 interrupted sutures, 8-0, 9-0, or 10-0 nylon. Fig 9.23i. 10. Conjunctival flap is reposited and secured by wet field cautery. 11. Subconjunctival injection of dexamethasone 0.25 ml and gentamicin 0.5 ml is given. 12. Patching of eye is done with a pad and sticking plaster or a bandage is applied.